My first question to you, Dr. Hofmeister, is about the recent ECOG trial, which now confirms the benefit of early therapy with lenalidomide and smoldering myeloma. So it would be great if you could talk about the trial and how would these findings support a change in clinical practice.
Excellent. Thank you so much. So this, we had the American Society of Clinical Oncology meeting in June earlier this month, and my boss, Sagar Lonial, described the ECOG 3A06 trial. This was a randomized phase 3 trial of lenalidomide alone or Revlimid versus observation. And it was patients enrolled in this had asymptomatic high-risk smoldering myeloma. Now, the definitions for high-risk smoldering myeloma are very confusing and different based on the protocol. In this protocol, patients had to have smoldering myeloma, which is greater than 10% clonal plasma cells on bone marrow biopsy, or greater than 3 grams of monoclonal protein in their blood, and they had to have a sufficiently abnormal serum free light chain ratio in their blood. This is what got them into the trial, and and that's sometimes different than other smoldering myeloma trials that you see, and it should be always mentioned in a setting where both potentially physicians and doctors are listening, that the words high risk that physicians use here are talking about high risk for the patient's smoldering myeloma to develop into clinically symptomatic active multiple myeloma. And once a patient develops multiple myeloma, then we use the words high risk to basically describe whether the patient is relatively treatment resistant and differentiate those patients with high risk from standard risk patients that are thought to be more treatment responsive and have a longer overall survival. But back to the smoldering myeloma ECOG trial that Dr. Lonial presented here in June. It looked primarily at 90 patients who were on lenalidomide in the phase 3 portion of the trial and 92 patients that were not treated with anything. And not surprisingly, the patients that didn't get treated with anything didn't have any response from their smoldering myeloma, but those patients who had lenalidomide or received that had about 50% of them had a partial response or better, and that's in line with what you'd expect from single agent lenalidomide. Interestingly, the quality of life parameters didn't seem to change in what was presented at the meeting, and the second primary malignancies, those patients who developed a different cancer during the period of observation of the trial, were very small. So it's just a couple cases, 4 cases in the lenalidomide group, 2 cases in the observation group, and I'm not sure really what to make of that yet because none of these patients had received any other chemotherapy. The story of the presentation was primarily the fact that those patients with high-risk smoldering myeloma, as defined by the current Mayo Clinic criteria, the 2220 criteria, which is greater than 2 grams per deciliter monoclonal protein, greater than 20% plasma cells in the bone marrow biopsy, and a serum-free light chain ratio greater than 20. Those patients had a clear benefit in terms of their progression-free survival, meaning how long their smoldering myeloma stayed quiet before developing into active multiple myeloma, and that benefit was not really seen in patients with low-risk disease or intermediate-risk disease. So we took away from this, hey, if you have somebody who has high-risk smoldering myeloma, patients who are exceedingly likely to move towards active myeloma, these patients seem to benefit from early therapy, and benefit is described here means delay before they develop symptomatic myeloma. We don't know yet whether they live longer overall, and that's going to be years away from getting that type of data, but these patients certainly delay before developing symptomatic myeloma. So that's the story with smoldering myeloma. It's new. The only previous big trial in smoldering myeloma was the Spanish trial, the QuiRedex trial that used Revlimid and dexamethasone. There were numerous kind of critiques about that trial regarding patient access and the evaluation of myeloma bone disease. That trial also showed a progression-free survival benefit, and it showed an overall survival benefit. So Dr. Loniel's trial kind of showed us that we're likely to see a progression-free survival benefit in the high-risk patients, and we don't know yet whether we'll see an overall survival benefit.
Thank you, Dr. Hofmeister. I'm going to be jumping to another trial right now, about the one where Daratumumab, on addition to the VTD regimen, showed longer PFS and a higher response rate as well, the CASSIOPEIA trial. So probably you could talk about this as well.
Absolutely. So this was a huge phase 3 trial looking at a 3-drug standard in Europe, Velcade, thalidomide, and dexamethasone, and versus Velcade, thalidomide, and dexamethasone with the addition of Daratumumab or Darzalex, which is an active monoclonal antibody targeted towards CD38 used primarily in the U.S. in relapsed myeloma. Philippe Moreau presented this data at ASCO again earlier in June. It involved approximately 1,000 patients, and these were all young, fit patients who were thinking about autologous stem cell transplant. So in Europe, that generally means those patients who don't have significant other disease and are less than 65 years old. They were randomized to receive VTD, which is the standard, or to receive VTD with Daratumumab. They then went on to receive autologous transplant, consolidated with VTD for 2 more months or cycles of treatment, and then randomized to receive Daratumumab alone or observation. So, and I glossed over this point, and it's worth mentioning, is that at diagnosis and at the beginning of the trial, patients were randomized 1-to-1 to receive Daratumumab with induction, transplant, and consolidation, or not to receive Daratumumab with induction, transplant, and consolidation. And then there was a second randomization, meaning that no matter whether you received Daratumumab with your initial treatment or not, you were randomized again, had a 50-50 chance of either having Daratumumab as part of your maintenance or having no maintenance. And so there's 2 parts to this, and they only presented data for the first part of the trial. And what they showed is that the addition of Daratumumab didn't really change the overall response rate at all. The majority of patients who have generally stage 1 and 2 revised ISS myeloma had about a 90 or 93% chance of an overall response. There were more stringent complete responses in those patients who had more effective therapy, meaning effective 4-drug therapy led to a higher response proportion than those patients who had 3-drug therapy. And if you look at the subgroups of this, you see that most of the patients responded very well, but those patients who had ISS stage 3 disease and those patients who had high-risk cytogenetics at diagnosis, their benefit was unclear with the addition of Daratumumab in terms of the odds that they would achieve a stringent complete response. The overall survival for this trial as well was not statistically significantly different between the groups, and that's not unusual because this trial's only had follow-up for about 18 months. So overall, this is a very large 1,000-patient plus trial in Europe using their standard 3-drug regimen, their VTD, and asking a question, does Daratumumab add to it? And the answer is that daratumumab slightly increases the response rate. It definitely improves the progression-free survival, but the improvement in the response was not really enjoyed by patients who had high-risk disease, and we don't know whether the addition of daratumumab as part of induction therapy will overall prolong overall survival. It's not unexpected to see an improvement in progression-free survival. In other words, how long your myeloma stays quiet, because you're adding you're using 4 effective drugs versus 3 effective drugs. So that's not uncommon. But the real question is whether this will lead to an overall survival benefit, and certainly we'll be waiting to see median follow-up duration as it gets presented at subsequent meetings over the next 2 to 5 years. So I think the question about whether to incorporate daratumumab in patients who are newly diagnosed with multiple myeloma, even if everyone was to do Velcade, thalidomide, and dexamethasone induction, seems to be very appealing in those patients who have standard risk disease, because they have a longer progression-free survival, they have a better response proportion, meaning more patients went into a stringent CR, and as far as toxicities went in this large trial, they didn't see a signal that was significant that they were having a lot more side effects, although it did appear that those patients who got daratumumab did have more infections than those patients who had 3-drug therapy alone. So I think people will wait for this trial to show an overall survival benefit, but it clearly regulatory agencies are going to get submissions about adding daratumumab to upfront therapy with VTD.
Doctor, my last question before I hand over to Gary and the panel, they have a lot of questions for you, it'd be great if you could talk about the role of precision medicine in developing myeloma treatment regimens, especially with a focus on the MyDrug master protocol.
Thank you so much. So this precision medicine has had a tremendous amount of hype and hope that we could target specific genetic abnormalities in patients with all types of cancers to specific therapies targeted towards that genetic mutation. That is, people understand this. It makes sense to them, but it's been hard to really show benefit, because many times these specific DNA mutations are in only a very small number of patients, and then showing that patients respond better or live longer requires sometimes very large and very complex so-called umbrella trials to show that they're doing better. So there are umbrella trials in numerous solid tumors. The BEAT AML trial is an umbrella trial for patients with acute myelogenous leukemia, trying to precisely treat those patients with characteristic abnormalities in a reasonable way. And the MMRF is sponsoring a large umbrella trial called MyDrug. And it's really the first myeloma umbrella study. And what they're looking for is to see patients early on in their disease course, meaning patients who've received initial therapy, whether it be just chemotherapy, whether it be chemotherapy and transplant, whatever they had initially with their to treat their myeloma. And then at the time of their relapse, if they have a relapse early on in their disease course and they have evidence of high-risk disease, meaning they've relapsed early, and they're not too sick, then these patients go on to get a bone marrow biopsy to essentially functionally target them to see what exactly genetic lesions define their myeloma from a large panel of known genetic lesions that are known to influence disease biology. And then, depending on what abnormalities are seen on that bone marrow biopsy, they then get pushed into a particular arm of the trial. So if they have activating mutations of all different types, they are then pushed to an arm of the trial where they both get therapy that is fitting and targets plasma cells, plus they get therapy that is a genetically targeted therapy for that particular type of mutation. Now, a lot of these mutations are not easy to talk about. They don't show up on your standard FISH or fluorescent in situ hybridization panel that you can get at any oncologist's office. Many of these mutations, they really need to be tested by sequencing DNA. So they're not available unless you're at a larger center, and specifically unless you have access to this study. And you can then and so the whole concept is to both attack the plasma cell with things that plasma cells are known to be susceptible to. So they're getting things like a proteasome inhibitor, an IMiD, dexamethasone. That's the core skeleton. And then adding on a genetically targeted therapy known to help specific genetic lesions. Now, there are really four main pathways here. The fifth one is on hold for the moment. This is a translocation between chromosomes 11 and 14, where previously venetoclax has shown significant benefit in this patient population, and at the moment, due to previous clinical trial results with venetoclax suggesting that some safety concerns need to be addressed first before we can add that fifth pathway into this protocol. There's really four main pathways, and if this genetic sequencing doesn't reveal that you have a specific abnormality where you'd fit in one of those main pathways, then you go to a standard grab bucket of, hey, there's no detectable alteration. Let's just do Darzalex or Daratumumab plus Ninlaro or Ixazomib, Pomalyst, and dexamethasone, and give that four-drug therapy both as, and learn about the activities for that control arm and compare all the genetically targeted arms against that main control arm. But we hope that even if we don't find that these four drugs or these four arms are the ones to use, we can in essence in the future swap out ones that aren't working, plug in another drug that might work better, and test it in this ongoing trial. As you know, people talk about these drugs as being cassettes that you can pull out of the protocol and then plug in, and that's what we hope to see here and be able to really bring precision medicine into the early relapsed myeloma patient population. So that's the goal. This trial had a number of patients be screened. I'm not sure if the first patient has been treated yet. I know it's opening up soon to accrual at my home institution at Emory University, so looking forward to that. And that's what I'm hoping that one of the successful future clinical trials is in myeloma.
Thank you, Doctor.